Dr. Eric Velazquez. Dr. Velazquez completed his medical training in both internal medicine and cardiovascular medicine at Duke University School of Medicine. He quickly rose to become the director of various programs at Duke, including heart failure research, clinical trials, and cardiovascular imaging, before moving to Yale, where he has been the section chief of cardiovascular medicine since 2018. At Yale, he leads a large and vibrant enterprise that includes being the physician-in-chief of the Heart and Vascular Center, deputy director of the Yale Center for Clinical Investigation, YCCI, and leading numerous NIH trials, including a special focus on underserved populations and expanding access to care for these populations. Dr. Velazquez will be speaking to us about management of ischemic cardiomyopathy, and we are excited to have him join us.
Thank you for the invitation. I'll just press got it here. This is a bit of a, first of all, this will be very informal. I am glad to be interrupted with any questions or glad to save those questions to the end. I kind of pulled this together with a way to try to highlight some themes that I've been working on over several years and some of what's the interesting work that's being done in our section as well. And hope this can be helpful to all of you. So here's, I don't know, I guess I'll just, okay, so that's my title. I'm going to focus on ischemic cardiomyopathy, but really, the subtext is, where do we position the management of ischemic cardiomyopathy, particularly interventional management of ischemic cardiomyopathy, in the context of the ride we're taking with guideline-directed medical therapy. And so hopefully I will hit these aims somewhat organically. They're not in any particular order in the slide, and as you see, the presentation won't really be ordered in this way, but I really want to give you a sense of where we've come from as it relates to the epidemiology of heart failure, particularly that with coronary artery disease. Just highlight the clinical course from acute to chronic heart failure. And it's through that, just share with you some, over this 30 years ride that I've been on, some of the failures, some successes, and where we are with regards to the evidence base for GDMT and how we've gone here. And then, kind of contextualize that information with information that we've developed as it relates to the role of revascularization, particularly for heart failure associated with coronary disease. And then a little bit on some of the work we're doing in implementation science and how we expand the evidence into practice. So that's the goal here, is just to highlight and maybe highlight the important role that heart failure has within our kind of global macroeconomic structure, which is, it really is to this date and probably for the foreseeable future, the leading cause of potentially reversible U.S. hospitalizations. And that's not something I'm proud of, but it is a remarkable opportunity. And you can see the impact of the lives and the inpatient stays that heart failure has in the U.S. And this is relatively recent aggregate data. And the impact as it relates to the cost is not only large, but expected to really hit over $50 billion in total cost by 2030. That's not because we haven't made some advances, but because the population is aging, and we've been successful as a global medical community in advancing the care of risk factors for coronary artery disease, as you'll see, and for heart failure in general. Prevention has extended the lives of patients so that they are actually living longer. And heart failure, from my perspective, is something that happens increasingly as we age. It's the potentially final common pathway for most cardiovascular conditions. So why am I focusing on coronary disease, and why has that been the focus of my career, frankly? And it really is because it remains and has been the most common cause of heart failure And it particularly affects those patients who are most at risk socioeconomically and demographically. Now, this used to be true in the industrialized nation, so-called nation. But what's also become quite evident, and I've been fortunate to be in this space as well, is the rapid impact that coronary disease is having in expanding the population of heart failure in low and middle income countries, where coronary disease used to be not so prevalent, but was really rapid industrialization in some countries. It has become not only a US or Northern European problem, but a global problem and a very common cause. So I want, particularly for the trainees, to just have you look at this graphic. And I think it comes from, I think, a very beautiful, very well done review by our society that kind of, highlights what is the key parameters in the course of the management of acute heart failure. Now, acute heart failure means different things to different people. I'm going to use the term not only hospitalized, but any, heart failure episode that requires urgent treatment. And in many cases, we can do a lot of that, not only in the hospital, but at home as well. And as you can see, there is these time windows where the focus is really on stabilization hemodynamically at times, and most commonly rapid decongestion. And that happens, with different, differently for different patients and under different conditions. But it really is the focus, that initial stabilization, initial hemodynamic stabilization and decongestion is the first focus. And I would throw in there, in the middle there, that is also an opportunity to, particularly for those patients who are coming in with an initial new diagnosis, to identify the etiology. That sometimes believe it or not, gets very short shrift in the heart failure, community. Because we're groupers, we're not dividers. So we try to pull everything together. But in fact, I would like to encourage us to think that really during that admission, during that initial hospitalization, is the critical time to affirm that heart failure is the etiology and not another cause. And we're sitting among people who do pulmonary retention work and others. And it's very important to highlight that and to understand if heart failure is the cause of the patient's decompensation, what is the etiology for that heart failure? I mean, it is something that should not be deferred, in my opinion. And your course may be drastically different for patients who have, ischemic heart disease or kind of hypertension versus, amyloid or sarcoid as a cause. And I think it is a time, and I encourage our trainees not to just stabilize and ship people out, but really to use this opportunity, because the rest of the course may be affected and people's prognosis may be close, very much affected. So then there is this time when we can transition to oral therapies, and that's really going to be a focus, a fair bit of my talk, around what we've gained in that time and why it's so important to initiate those oral therapies as early as possible, and the data that supports the safety and efficacy of that early initiation and titration, and then obviously engage them in close follow-up for additional therapies. And I'll use that as a framework to discuss what we've learned about revascularization. So just to highlight, again, my goal here is also to highlight some of the work from some of our own faculty. So we are clearly aware now, thanks to the work that Jeff and others have done, some of it here, that diuretic resistance is really commonplace among hospitalized heart failure patients. And here's just some of his initial work physiologically to suggest that the diuretic response in heart failure in terms of effective urine output is much different than patients who are not in heart failure. And so, your management of the diuretic or decongestive approach needs to take that into account. Now, I'm going to just highlight some of our own work along the way. And one of the interesting questions, day-to-day questions, was how do we decongest patients, right? I mean, we all think, everyone uses diuretics, all the time. 90% plus of heart failure patients are treated with diuretics, particularly during acute exacerbations. But we know very little about how to use diuretics, what choices should inform that. And much of the diuretics that we use were developed and brought to market in an era prior to our focus on developing randomized data to support use. So we took this challenge on many years back and built out this program called the Transform Heart Failure Program that we've now reported upon, which was a very simple, pragmatic question, which was based on a lot of smaller physiologic and some small outcome studies with meta-analytic summaries. There was a sense among the community that there were differences pharmacokinetically and maybe in terms of outcomes between commonly used loop diuretics. And so we were able to address this question in the Transform program, where we randomized patients to torsemide and furosemide and looked at all-cause mortality as the primary endpoint with other important endpoints. And we did this, and completed this actually enrolling pragmatically during the pandemic. This was our result. And, I think it was disappointing. It was certainly opposed to what the evidence to date that was available would have suggested. But I think it reaffirms the fact that, decongestion by any means is probably the goal. And it doesn't really matter if you choose torsemide or furosemide, that the effect and the event rates were almost identical, really doesn't make any difference. And I think this is consistent with kind of a decade plus of work that and many failed results, so to speak, important trials, but not the results we were expecting, where we were focused on, the construct of facilitating decongestion early in acute heart failure. And this is one evidence with the vasodilator ularitide, but frankly, there is a graveyard, and I, worked with many folks on these set of drugs that went all the way through phase 2 to phase 3 large trials to address the concept that we could have kind of a STEMI approach to acute heart failure, an early acute decongestive facilitated diuresis approach, and that short treatment would have a long-term outcome for our patients. And at the end of the day, I'm going to leave you with a slide that says we failed. That I think the evidence would suggest that might perhaps simple-minded strategy of just early decongestion through any means and aggressive vasodilation is not the panacea that we had hoped for. So where are we heading in this field? And I think I just leave you with this very important, paper that comes from Yale, led by our team, that looks at taking the data, taking our understanding of diuretic resistance and the reality that we have these loop diuretics that we need to use because we need to decongest people, but we don't really know how to use them in a targeted manner. And I think the future work that I think is going to go in this early part of this course of heart failure is going to be about how we can titrate diuresis effectively. I mean, it is kind of amazing that we do this day in, day out, and we really don't know how to choose the diuretic dose, and we don't do it systematically. Think about where we were with heparin dosing 20 years ago before we worked on that, and now we have heparin pathways. Well, I think we are going to be moving in this direction to develop the evidence base for diuretic pathways, so more to come. So now I'm going to shift gears and kind of take you further along that clinical course and focus on what I think is the most important element of management in this day with regards to heart failure, which is actually figuring out how to initiate guideline-directed medical therapies for heart failure. So I think these are disease-modifying agents. I mean, I think that term is one we're comfortable in rheumatology nowadays. I would have asked you to think about this the same way, that there are now 4 pillars to the treatment of heart failure that modify disease progression in ways that we would have really not expected it to, even a few years back. And those pillars include ARNI, or angiotensin receptor neprilysin inhibition, beta blockade, mineralocorticoid receptor antagonists, and SGLT2 inhibitors. And I'll just take you through very quickly some data on supporting these elements in this new approach to heart failure management, which is early decongestion and then as quickly as possible initiation in hospital, hopefully, of these 4 pillars of heart failure therapy. So what does this get us? Well, I would argue that GDMT, as it's been currently developed, provides massive risk reduction. There's an all-cause mortality relative risk reduction of over 72%, an absolute risk reduction of over 25%. And to have an impact, you really only need to treat a few patients for a couple of years to see it. And I think this comes from extremely well done, randomized, controlled trials that have done work of building upon each other to develop this evidence base. What does it do? It extends life. And here's the curves. You can see quadruple therapy, an extension of over 10 years of life versus triple therapy versus double, two agents. So again, this data, I think, is quite strong to support that this really has to become the focus. I think the era where we were focusing on that early period and trying to treat this as an acute event that we could treat for a short period of time and then reset the path. We've kind of figured out that didn't work. So now our focus is on GDMT. So where does this evidence come from? Well, I'll go back to some of the work that was done, frankly, in the office next door to me for a few years back that really looked at the concept of beta blocker initiation. For some of you in the audience, not a lot of you, maybe Mark, Jeff, a few others, remember that when we were house staff, if we were stupid enough to start a beta blocker in the CCU for a heart failure patient, we'd be yelled at. I very much remember my mentor, Rob Califf, who's the current FDA director, yelling at me for doing that. And it was just, foreboding. You couldn't do that because those patients, you'd reduce their contractility and you'd have worse outcomes. Well, it really took, and I also will highlight that many of you also remember that we used to admit patients with heart failure to the hospital to initiate a beta blocker. And that was also common. We've come a long way. But it took the kind of pragmatic approach of a randomized trial to ask the question, well, if we initiate in hospital a beta blocker, what happens? And this is one of these, early initiation trials that I usually come to because it set the stage for a lot of other good work that we've replicated with other drugs. So when that happened, when we started carvedilol in hospital versus waiting 90 days, you could see the curves were very clearly distinct in favor of early initiation. And this kind of set the stage and concept for not withholding beta blockers or in this case, any therapies until people were stable and in the outpatient setting and hoping that we could work against, clinical inertia and get these things started, but to really focus early on. And that's a message I want to leave you with. We took that a step further with the development of the ARNIs. There was evidence in the stable chronic heart failure patients under certain conditions that medication was effective, but it wasn't getting a lot of traction. And so we took on the question of asking whether we could initiate safely the ARNI in hospital, and what that would do with regards to outcomes. And as you can see here, we were able to show that compared to the active comparator enalapril, we had a pretty large reduction in the primary endpoint of NT-proBNP, and that translated into a substantial improvement in outcomes pretty early. This was an 8-week study, and you can see pretty large differences in a composite of major clinical endpoints. And again, this was not even against placebo. This was against an active comparator enalapril. It actually mattered if you, and we asked the question, well, if we started it after 8 weeks, what's the effect? And I think what this slide is meant to represent is you never can catch up. So if you don't take the chance to initiate the therapy early, you lose out on the opportunity to reduce those hospitalization events and potentially more morbid events during those first few weeks. And so again, highlighting the importance of early initiation. Well, now we've seen that not only in the outcomes in the NT-proBNP, but in other markers of risk, such as troponin. Troponins are much lower. Troponin release is lower if you initiate these drugs early. Markers of cardiac remodeling or adverse remodeling are different. So I think there's a pretty strong evidence base, not only from the translational and biomarker data evidence, but also with clinical outcomes that at least for beta blockers and ARNI, we should initiate early to have an impact. It also, I think, this is just data that we're in the midst of putting out there, but just to highlight that when we looked at this, not only in those with reduced ejection fraction, but with more preserved ejection fraction, that the impact was pretty consistent without any heterogeneity until the very high ends of EF. So I think our strategy now is really to approach patients pretty consistently, regardless of EF, in starting these medications, particularly if their EF is not normal, meaning 60% or less. What about SGLT2 inhibition? So I think there is, these studies are less focused, but if you extrapolate from the data from the large guideline evidence-generating trials of SGLT2 inhibition, the story is pretty consistent that if you can initiate early, your impact on reducing future outcomes is stronger. And I think this is from the DAPA work, and then this other study which was published in Nature I think last year. MPulse also suggested that there was clinical outcomes to support early initiation of SGLT2 inhibition. And in our guidelines now, ARNI and SGLT2 inhibition and beta blockers are considered a class 1 indication to initiate in hospital. There are other things that are being evaluated, whether we can focus on iron deficiency, as it also there's some strong evidence developing for that. And so in my practice, I think we try to encourage people to search out for iron deficiency anemia among heart failure patients. It's quite common, and to treat that as well in hospital. And also, when you look at the data from a randomized trial, which was called Strong Heart Failure, published in a Lancet and a Korean heart failure registry, I think the evidence is both pretty compelling that early initiation of GDMT, these 4 pillars, is not only doable, but optimal for outcomes. It's also quite cost effective. And you can see here that in terms of quality, cost effectiveness ratios that are considered beneficial, all these therapies tend to hit the mark as it relates to parameters that are usually acceptable. Now let me turn now for the rest of my talk to focusing on a few other issues, which is the treatment, particularly once you've identified the etiology of coronary disease, and maybe a little bit on how we're trying to do better than just evidence generation, but actually speak to how we implement and what the evidence for implementation is. So first of all, just to highlight that we have more than just medical therapies for heart failure now. We do have CRT, or implantable cardiovascular defibrillators. We have some evidence for both that part of the population that has mitral valve disease as well. And so I encourage you to search for those patients at risk for sudden cardiac deaths. At this point, it's predicated on an ejection fraction, and to look and to evaluate in a continuous fashion the severity of mitral regurgitation on therapy and see if people are good candidates for those approaches. But my focus has been traditionally on that population with coronary disease. And again, I started by saying this is the most common etiology by far globally for heart failure. But we don't really search for it too well. And this is data that asks the question, well, how common within 90 days of a hospitalization for heart failure do we evaluate whether patients have any history of ischemic heart disease or coronary disease? And it's kind of depressing. It's very uncommon. We do not test for coronary disease in these patients very frequently. I think in a place like Yale, I would suspect that that's much higher, but this is a fully insured population registry. And this analysis suggests that even among the well-insured, our ability to establish coronary disease as an etiology, which we might treat differently, is actually quite poor. And so maybe a take home to not let that happen to your patients. When we looked at pretty much all the hospitals in the Get With the Guidelines American Heart Association Heart Failure Registry, you could see that only 40% had any coronary disease testing within the first 90 days. And that was more common among those patients where an echo suggested a low ejection fraction, and less common among patients who had more middle to preserved ejection fraction. So my opportunity to highlight that this is a really missed opportunity. Now, part of the reason why we haven't been looking consistently is because for many decades, coronary disease was felt to be kind of a secondary issue, and that really treating it didn't have an impact on the trajectory of patients with heart failure. So I refer you to the slide. I use this slide a lot. Maybe many of you have seen this before in a presentation I've given in Grand Rounds for Medicine. But I just want to highlight that 50 years ago, the founder of the Association of University Cardiologists and at that time, the editor-in-chief of the American Heart Journal, this is what they said about ischemic cardiomyopathy, that it was myocardial dysfunction that resulted from occlusive coronary disease. It was the most common cause then, and it still is. And apparently, once the damage had occurred to the extent of ischemic cardiomyopathy described, the disease was irreversible, even with absolute bed rest, which gives you a sense of what we were doing with patients 50 years ago. So we've come a long way. And this hopefully sets the stage for the progress that's been made since then based on data. So many of you, a little older generation, might recognize that this formulated the guidelines, the results from the coronary artery surgery study formulated the guidelines for 3 decades on how we approach patients with coronary disease. And it really was in the group with multi-vessel disease and a lowish EF that was really a very small proportion of patients, less than a couple hundred enrolled, where the evidence was available to generate the guideline for cabbage as a treatment of coronary disease. And this was an era when we didn't have the medical therapy that we have now for coronary disease. So it was also found from that program that if you had heart failure at presentation, there wasn't really an advantage with medical versus surgical therapy from the CAS study. So this was probably true in that era when medical therapy really didn't exist, and really set back the strategy of approaching revascularization in these patients, because it was felt that once you had heart failure, you were too far gone, and the evaluation and or management of coronary disease was not going to give you much benefit. It was at Yale, and Barry Zared was someone who I knew then, but many others, John Eleftheriades and others were involved in this work, where the construct of revascularization reversing LV dysfunction came from. And this was in single center studies and surgical series that suggested that you could reverse LV dysfunction if you provided blood flow. For those in the audience and myself now, it seems almost ridiculous that that had to be proven. But it was the case that this was challenging the dogma that had been established by the landmark coronary artery surgery studies. And the early case series suggested improvements in ejection fraction and reasonable safety, although it's clear that there was only one line because there was no comparator arm in this series. We, this was one of my fellow projects when I was training, asked a question using the large Duke catheterization-based data registry of what the impact in our experience was, and this was over a 25-year period, and this generated interest in the fact that, well, maybe there was an early hazard, but when you looked at our data long-term, regardless of the EF, regardless of the age, and regardless of the symptoms, if you revascularize patients, you had an advantage. And that stimulated some work that led to a program that I spent 20 years on, which was a program called STITCH. And these data probably are old, but just to highlight for you what STITCH showed, which is the surgical treatment for ischemic heart failure, was that if you identified the population was coronary disease and heart failure, and you applied surgical revascularization to those who were eligible, you had an absolute risk reduction that was quite large over 10 years. There was an early hazard because surgery is risky up front, but about at the 2-year mark, you started accruing advantages to the coronary revascularization arm. In this case, was cabbage. And so I think this kind of establishes the evidence for revascularization in a non-acute setting. Most of our evidence for acute revascularization comes, with PCI in a primary treatment for STEMIs, right? All the other therapies, all the other trials for revascularization has never shown an advantage in chronic therapy. This was one of the first times that was the case. And it's probably because of the risk of the population and the fact that there's more myocardium at risk because of the reduced function. But I would caution you that, this was in an era before we had ARNIs and SGLT2 inhibitors. So we have to, while not that old, I think we need to continuously reevaluate the role of revascularization in these types of patients. When I looked at other events, there was pretty consistent effects across all fatal and non-fatal events of interest, suggesting a very large relative risk reduction of 28% for reducing cardiovascular mortality or hospitalizations. The impact on quality of life was pretty consistent with the clinical findings. And in pretty much every simulation and strategy using the real data, it was a very cost-effective approach the use of coronary surgical revascularization in patients with ischemic cardiomyopathy. Now, where does that leave us now? Well, when we were funded to evaluate CABG, we actually approached it as a 3-arm trial with percutaneous revascularization as a 3rd arm. And we got guidance and feedback that led to the design of the stitch trial I just presented from the NHLBI that said, hey, you can't do that. You have no evidence to support the safety of PCI in that cohort. And so we were, really, and that was true. And so we actually did stitch as a 2-arm trial to establish the effect with coronary surgery versus medical therapy, as we did. But the question is still out there whether we can get the same effect revascularizing by any means. And I say I don't have the answer to that. I'll show you where we are and where we're going. But it is important to highlight that PCI and CABG are not equivalent strategies, and particularly in patients with reduced LV function, there might be kind of limitations to a very focused revascularization strategy that just highlights fixing fixed lesions versus maybe more comprehensive and complete revascularization to enhance distal collateralization that we do with CABG. And there might be different reasons for that. And I think my personal opinion is that with CABG, we do more to prevent future infarcts and really the effect on LV function is probably a secondary issue. It's not the driver of the outcome effect. But that's my perspective right now. When we studied PCI in registries, and this is from a Canadian large provincial registry, it does appear to underperform CABG in these populations. So in these registries where every patient's accounted for, and every procedure that's done is accounted for because it's paid through the government, you can see that there really doesn't appear to be an early advantage of a PCI strategy versus a CABG strategy, and the long-term effects of CABG versus PCI among similar patients, as best we can, controlling for outside of a randomized trial, suggests that PCI doesn't provide the same long-term advantage. Now, when we've evaluated the question of PCI in stitch-like patients, and this was the REVIVE study recently published, it appears that PCI did no better than medicine for the population that was enrolled in stitch. Now, that's still being reviewed and kind of discussed, but this is the only randomized trial of percutaneous approaches to the chronic revascularization of ischemic cardiomyopathy. These were patients who were not offered CABG. So those patients would have been excluded. There are many reasons why patients prefer not to pursue CABG, obviously. Everyone prefers a non-operative approach if possible. So it is important to establish the role of this therapy. And we're now very much focused on looking at whether we should further study this. And I'll share with you a little bit about what we're doing in that. So I've taken you very quickly through a lot of different themes, but here's where the guidelines are as it relates to the construct of GDMT, PCI, and CABG. And so clearly, everyone should be, I think, the etiology for heart failure should be established for everybody, and everyone as early as possible, and hopefully initiated in hospital, should have these 4 pillars started. Now, we have used hemodynamic approaches that allow up titration in a titrated fashion, using blood pressure as a surrogate for up titration. So as long as the blood pressure is above 100 systolic and there's no adverse effects on potassium or symptomatic hypertension, we just push on and try to get all these agents on board. In the population, once GDMT has been established, that has coronary disease, there is evidence from Stitch that suggests that they should be offered surgical revascularization. So a patient with multivessel disease on GDMT who has reduced LV function, based on our guidelines, that person should be evaluated regardless of the presence of ischemia on testing or regardless of their viability status, which myocardial viability is a different talk. The evidence and the guidelines would support chronic revascularization with CABG. PCI, I've shared with you the totality of the evidence from large-scale registries, and the one single randomized trial is not yet ready for prime time. Having said that, many of our patients would prefer that, and many practitioners still offer that. And I think it's really an evidence, a zone where evidence needs to be generated, and we're still, doing that. So that's where this comes in, and we're in the midst of this international collaborative that we're building to fund a follow-up PCI versus CABG comparison for this population to get a better understanding of the role of PCI relative to GDMT plus CABG, and more to come on that. So I'm going to leave you with a few other thoughts, and this is just something that I hope you understand where I'm going with this. Heart failure arguably is a biological condition that can be treated equally effective regardless of who you are and where you live. But if you look at the US map and you look at where heart failure mortality happens, you see a substantial heterogeneity in what happens to patients who are hospitalized with heart failure. And I think that reflects not only on the social determinants of health, but in our ability to implement strategies systematically for our patients. And there's a lot of work that needs to be done to flatten this heat map a little bit. And I think that's where our group has been focused on. And I think we've built a team here, and it's really, I give credit to folks like Nihar Desai and Tariq Ahmad and others that are really pushing us beyond the kind of randomized controlled trial of my era to new evidence generating practices. And encourage you to read this very nice editorial of theirs. But what we know is that we have a very good sense of what are the elements, the parameters, the covariates in heart failure scores. But in our own data from Yale across our whole network, we can actually discriminate pretty well outcome. And it's very well calibrated to these parameters. And this has been done in thousands of patients within our walls and used to generate prognostic maps and models. The question is, does that help? If we give people that information, does that help? We did a study, and this is where I think the future lies in evaluating the implementation of data. We did a study called Reveal Heart Failure that suggested that just providing people prognosis, information prognosis doesn't really change their prescriptive behavior. I encourage you to read this study to go into some of the details. But the take home is giving people information about prognosis is not enough. You need to provide them, I think, systematic strategies for prescriptive behavior. And so, there's a lot of great evidence, but we have implementation gaps, and poor implementation does not help patients regardless of how good the evidence is. And so that's the focus of the work they're doing these days. And one example of that is the PROMPT HF study that was recently published, where we provided not only prognostic information, but actually built in strategies to actually guide therapies and its utilization among practitioners. And this is a little bit of the EPIC sheet that came up when you were randomized to this approach. This was IRB approved and done within our walls. And what we showed was that if you could prompt people to know about, hey, are you a patient on GDMT? Can you start it? What's in the way? We were able to not only evaluate and enroll thousands of patients pretty quickly across our network, and this was during the pandemic, but that we were able to show, and this got a fair bit of press, that this nudge led to a behavioral change that is associated strongly with better outcomes. And that was, I think, a nice win. And I think my sense of where a lot of this evidence generation needs to go is to take us beyond the randomized evidence to implementation. So I've taken you through a pretty quick kind of presentation on what I think are interesting aspects of the work we're doing in heart failure here and some of my own work. So where are we now? I mean, I think I leave you with these thoughts. Please, when you approach a patient who's hospitalized with heart failure, make sure you understand the extent of coronary disease, which I think should be assessed on all patients, and approach and initiate GDMT early for all patients, regardless of their EF, actually, but particularly in those who present with reduced EF. And I think I've shared with you some ways that we're approaching how to hasten implementation of GDMT. The data from revascularization of ischemic cardiomyopathy tells us we've come a long way. We don't let these people sit in bed anymore like we did 50 years ago and think, we just want to help them stay alive and probably cause more PEs than anything, actually, and hasten mortality, but nonetheless. What we know now is that, CABG improved survival with less morbidity compared to medicine, but we don't stop with that. The evidence generation is something that has to continue. We now have new approaches to medical therapy that were not available in the era when we did those trials. And I think we have to continuously reevaluate the effect. I didn't talk about it, but I would think that there are blind alleys that we are suggesting people don't go down. I think, understanding viability is interesting. Understanding whether people have angina or no angina, or ischemia, no ischemia are interesting. But none of these parameters had an effect on the outcome of CABG leading to better outcomes versus medical therapy. I think the mechanisms of revascularization are multifactorial. And PCI, while less well studied, has some potential, but the data to date has not been really very supportive, and we need more. I didn't talk a lot about the population with normal EFs because we really have very little data in that population, and that certainly needs more study. So with that, hopefully this was helpful to all of you, and glad to take any questions. Thanks for your attention. Gave us 10 minutes. That's good.
All right. Thank you, Dr. Velazquez, for that great and informative talk. I'll start off with a question. As part of our division, we take care of a number of heart failure patients in the ICU with exacerbations. I know you mentioned this at the end, but a lot of the data for heart failure with preserved ejection fraction isn't there. And do you have any I'll start, it's a two-part question in terms of diagnostics and therapeutics. Diagnostically, should I be thinking about, after stabilizing them, calling a cardiology consult, stress testing, nuclear stress test in-house, or waiting for the outpatient setting? What are your thoughts about hemodynamic assessments, and if there's a value in a right heart catheterization early on in their course to make a diagnosis, or are assumptions good with metabolic syndrome, obesity, reinforcing my assumption that they have heart failure with preserved ejection fraction?
That's a long question, but I'll try to shorten my answer. And I recognize that I'm sitting here at the home of nuclear cardiology. But in my view, if someone is managed in an acute setting, even in a critical care setting for a heart failure, I think you need to have an understanding of their anatomy. And so my strategy, frankly, has been to focus on establishing the anatomical extent of disease. That's something that, I think everyone needs to assess on a patient-by-patient basis, but it is, I think, a good strategy for the majority of patients, again, and assuming the prognosis is not limited by other means, to pursue right and left heart catheterization to establish not only their filling and hemodynamic pressures, but also the extent of coronary disease. Now, the only caveat I would say is that our advances with regards to non-invasive anatomical imaging have really, they were not there 5-10 years ago. They are there now. I think in many situations, initiation of GDMT in a hospital stabilization, and then if your pretest probability is not super high, then I think pursuing CTA, coronary CTA at a later point to establish that there's not a left main or high or large proximal coronary lesions is, I think, a very reasonable and acceptable strategy. But that's kind of how I approach it. I will say that not everyone agrees with me, and I think the construct of whether you should pursue physiological testing versus anatomic testing. We did that study in PROMISE. We did, a few years back. I think both strategies are okay, but for the reduced EF population particularly, I think anatomy, you need to know the anatomy. That's going to drive your treatment. Mark, and then,
So thank you, Eric. You made a really interesting comment about, in your New England Journal study 2016, about how something might have been true in 2016 with respect to the later development of medications like the ARNIs. And it reminded me of what we face in critical care, is that context matters. Like some treatment might have been grade A evidence in 2005, but then the state of the art changes over time. And so particularly for bundled treatments like this, how do you unpack the individual benefits of a multi-component set of therapies? Like, are they being studied individually, and then is there an assumption that they all are important, or is there some sort of synergy that you need to take into account, or maybe even start to think about subtracting some of the therapies?
So I think it's a great question, and I'm not sure I have a great answer other than to say that the medical therapies that were evaluated were always evaluated, except for the ACE inhibition, really, as against an active comparator, right? They were always, reviewed relative to the standard. So I have substantial confidence that the pillars that I shared with you are built on, on a pretty strong, evidence base, and their effect are additional and above and beyond what was the prior, right? Now, as it relates to CABG, that the reality is we had, fantastic medical therapy that was consistent and monitored through our trials. But, we didn't expect ARNIs and SGLT2s when we were doing that trial, and they weren't available. So we did the best based on the evidence we had. Jeff, maybe others might have different perspectives on this, but my approach to that is to say that what the addition of a new standard of medical therapy does is reduce the absolute risk of the population, right? But the relative risk shouldn't really change, in my opinion, is particularly if you're addressing a different kind of physiological parameter, like coronary disease revascularization. So I would suspect, if I was a betting man, that for me to get the results that I got at Stitch now, I'd have to enroll more patients and follow them longer because the absolute risk has definitely come down. And, but we have to do that work. I think the challenge for those of us who are interested in kind of the clinical trials arena is how to do that in a facilitated way, pragmatically at a lower cost. Because we can't repeat trial after trial every 5-10 years. And I think that's where understanding how to do registry randomized trials and other kind of approaches comes in. And I think there's a lot of excitement in that area. So I don't know if I've answered your question, but I think a pathway is to always be developing evidence based on the latest available standard. Yes.
Thank you so much for your talk. I'm so happy that you mentioned implementation because you're right that no evidence is helpful if it's not implemented to the population. I was wondering what you know, and I know it's actively being studied, but what you know about the barriers to implementation and if there is any disparities between either gender or racial ethnic disparities between how GDMT is being implemented.
Yeah, so I can tell you that the answer to that last question is absolutely. There are barriers and there are differences in GDMT implementation by social parameters like race or the lived environment or what have you. And I think, what I would encourage, I think there's a great area, a field to go into is understand the methodologies of implementation science. For those as a cheap plug, we have a T32 that Donna Spiegelman and I have in implementation science funded by the NHLBI. So for those of you who are lung investigators, we have spots. We'd love to see people join that training program and to understand how to understand the methods and how to apply implementation principles. I guess I would leave you with a sense that implementation, as Mark suggested, context means everything, right? So the implementation strategy that works in one context doesn't necessarily mean that that's going to be the same implementation strategy in a different context. So you have to, I think, define the question really well. If your focus, like mine recently, has been on kind of how to nudge academic health systems to do certain things, well, then you can compare academic health systems. That's a larger group. But if your focus is on trying to bridge that implementation gap between Black and white patients in heart failure, then you should study that patient context more formally, because the data you'll generate will be applicable to those patients, and that's how I would approach it. I don't know if I've answered your question, but try my best. Thanks, Jeff.
There's comorbidities, there's potential sepsis, and we often say, well, it looks like heart failure is a big part of the problem. We approach those patients, so I'm kind of wondering, in the end, you've dissected out heart failure, talked about it somewhat isolated fashion, but how do comorbidities affect symptoms? And in terms of implementation, our desire to take care of these patients in this way, should they transfer to a cardiology service as their that's a loaded question.
No. I love it because the answer that the cheat.
I think that for us is a very important thing here.
Yeah.
Because we see a lot of patients in this realm, and we can't really tell a lot of times if we are doing the best for them. And are we really enriching or finding those people? As you said, look for those patients that have X, Y, and Z. So in a medical ICU, what should we be doing?
Yeah, so first of all, I want to just highlight, for the purpose of any talk, but certainly I did, have oversimplified the problem, right? You know, to focus on a few areas and clearly, I think the majority of patients with heart failure frankly don't end up in critical care ICUs that often. You know, I think we're seeing in an academic health system, and you particularly are seeing a subset of heart failure, which is a global problem that I think was really the area that I was focused on. So I just want to state that to be obvious. The comorbidity question, I think it was raised again. You know, comorbidities drive outcomes for sure. I think comorbidity, the impact of it as a driver, I think is particularly focused in what we call the preserved EF population, where we have less evidence to support treatments than in the reduced EF population. As it relates to your question about what, you know, after initial stabilization, like I shared with you, like, you know, I'm disappointed. I wish we could be doing something in that acute period other than medical stabilization, decongestion, that I can tell you is gonna, you know, reduce the, you know, we've done everything same. So I think our approach in the units is hemodynamic stabilization, decongestion, like and the management of the other maybe drivers, if they're comorbidities or other elements. To your question, and I know why everyone laughed, and I'm laughing too. You know, I'm answering this as the chief of cardiology and the service line director for the Heart and Vascular Center. Yes, once that stabilization and decongestion has started, I do think that there is an opportunity to engage, particularly heart failure cardiologists, but across all of cardiology, that expertise to try to drive treatments in ways that we take care of, you know, revascularization, you know, all those elements. So I think it's very reasonable, you know, if patients are evaluated, you know, by cardiologists when they are, you know, admitted with heart failure. I think that's to me should be the case. So you can, you know, highlight me when you say that. But that doesn't mean that, you know, I think the issue is when people are in critical care units, it's hemodynamics, instability, and stabilization, and you know we don't have a 50 patient CICU. So
Okay, we are past the hour, so thank you for this
thanks.
talk.
Yeah.
And enjoy the rest of your day.
Thanks for organizing this, Kevin. Thanks for the introduction.